Looks like we still got a few people joining, so we'll just give it another moment or so, and then we'll start with the webinar. Good afternoon and welcome to this week's Wednesday webinar. My name is Fiona Robinson and I am the series host. In this week's webinar, we will discover a treatment option from HEMA Biologics for the hemophilia community. We'd like to extend a special thanks today to HEMA Biologics for sponsoring this webinar, and we appreciate their support of the entire National Bleeding Disorders Foundation Wednesday webinar series. This webinar is being recorded. The recording will be available shortly after it ends on the NBDF website, bleeding.org. We encourage you to ask any questions you may have today. You can ask your question by using the Q&A feature at the bottom of your Zoom screen at any time during the webinar, and following our speaker's presentation, we'll put your questions to them. Unfortunately, for technical reasons, we will have to end the restream to LinkedIn, Facebook, and YouTube just before the Q&A session. So if you want to be part of that live Q&A, please make sure that you are joining us via the Zoom platform today. And in just a moment, we'll pop a link into the comment section of those platforms, LinkedIn, Facebook, YouTube, that you can use to come on over and join us in Zoom. Our expert guest today is Dr. Guy Young, Director of the Hemostasis and Thrombosis Center at the Children's Hospital Los Angeles. I'd like to thank Dr. Young for joining us today, and I'll pass things over to him now to get us started.
Okay, welcome everybody, and glad to be discussing this medication called 7-Fact with you. So we'll just get right into it. It's just a little bit about me. I work in Los Angeles at the Children's Hospital Los Angeles Hemophilia Treatment Center. So here's what we're going to be talking about today. We're going to take just a slide or two to talk about inhibitors in general. And the reason is that 7-Fact is indicated only for patients who have inhibitors, and we'll get into that indication shortly. And then, of course, we'll talk about what is 7-Fact, how was it studied, the results of the pivotal phase 3 trial, which is called Percept 1. And then we'll close with why you might consider 7-Fact if you would be eligible to receive it. And then just briefly about patient support programs and where you can learn more. So the bulk of the talk will be those second, third, and fourth bullet points. So hemophilia A or B with an inhibitor. So what is an inhibitor? It's essentially an anti-drug antibody. So it's an antibody that's directed against factor VIII if you have hemophilia A, or factor IX if you have hemophilia B, basically rendering factor replacement ineffective. So in other words, you can't use factor for prophylaxis and you can't use factor to treat bleeds. There may be reasons why, if you have an inhibitor, you would be on factor, but those are more related to something called immune tolerance, which we won't be discussing today. And there are different ways of measuring the amount of the inhibitor, and it's an assay that is measured in units called Bethesda units. It was developed at the National Institutes of Health, which is in Bethesda, Maryland, which is how it got the name. If you have less than 5 Bethesda units as your level of inhibitor, we call that a low titer inhibitor. And so that means that your body has a relatively low level antibody that blocks factor VIII or factor IX from functioning. In that case, you may, and this is between you and your physician really, and you and your HCC team, but you may be able to use factor VIII or factor IX, just you'd need higher doses. But that's fairly uncommon. Most patients have either a high titer inhibitor, meaning greater than 5 Bethesda units, which means it's a very strong antibody response, which means giving factor to treat a bleed won't do anything. It'll be like essentially squirting the factor into the sink would have the same effect, if you will. And most patients who have inhibitors have high titer antibodies, in others greater than 5 Bethesda units. And we consider inhibitors, at least certainly now in these modern times, the last 20, 30 years, that this is really the most serious complication in hemophilia. Sorry, clicking. I clicked the wrong way. Yeah, so hemophilia A is just listed on the right. You're just showing the antibody to factor VIII in the little cartoon, and then hemophilia B is the antibodies directed against factor IX. Who might develop an inhibitor? Well, it can occur anytime, but most often will occur within the first 50 exposures to clotting factors. So typically, if somebody is going to use factor VIII or factor IX for prophylaxis, we usually start that at a young age. And so typically inhibitors develop in young patients, usually less than 5 years of age. With hemophilia A, we're living in a little bit of a different time now, and soon hemophilia B, where not everybody will use factor for prophylaxis, but the rule of 50, we think, still more or less fits. Also, inhibitors are much more common in hemophilia A. Around 20% of patients will develop an inhibitor, especially a high titer inhibitor, and in hemophilia B, it's about 3%. And who is at higher risk? We know certain categories of patients are at higher risk for developing an inhibitor. First of all, it's far more common in patients with severe hemophilia A as opposed to moderate or mild, although it can happen in patients with moderate and mild hemophilia. I have a couple of patients with mild hemophilia, one with moderate hemophilia that developed inhibitors. So it does happen, but it's a lot less likely than in severe hemophilia. People who are not or people who are Black or Hispanic, they have a higher rate of inhibitors than white or Asian patients. People who have a family member with an inhibitor are much more likely to develop an inhibitor, and people with certain genetic mutations of hemophilia make it more likely to develop an inhibitor as well. And so the last sort of section here on inhibitors is that we still have an unmet need when it comes to on-demand bleed treatments. On-demand bleed treatment essentially means we're treating when there is a bleeding episode. And even though we've had advancements in prophylactic treatment and we may have less annualized bleed rates, in other words, the number of bleeds per year for patients has gone down, but breakthrough bleeds still occur. If you look at the studies of all the various new drugs that we have for prophylaxis, none of them has a zero ABR. None of them has a 0% bleed rate. So all the patients, even on those medications, are likely to have bleeds, and inhibitor patients are no different. And oftentimes in inhibitor patients, we take a day or days to resolve the bleed. So it's typically more than one day of infusing to get a bleed resolved. It does often require multiple infusions. It's the rare situation where one infusion in a patient with an inhibitor will stop a bleed, and rebleeding is common. And so we'll talk a bit later about the results of the 7-FACT trial. And the reason we bring these up is to make the point that maybe 7-FACT has the ability, I say maybe now, and you'll know later for sure, to resolve bleeds more quickly, with fewer infusions, and with less rebleeding. And so that's why those points are made on this slide. So kind of just try to keep that in mind as we get into the 7-FACT data. And then early treatment of bleeding episodes is really important. I mean, the longer that, once a bleed starts, the longer that you wait or the longer it takes to put an infusion in, the more severe that bleeding episode is likely to become, because as more and more blood accumulates in the joint, not only is it more painful, but it's going to take more time for that bleed to fully resolve. So treating quickly and early is very, very important. This is for patients with and without inhibitors, to be honest with you. So treating quickly and early will reduce the chance of potential significant side effects, or not so much side effects, but the effects of the bleed, which is joint pain and swelling. And oftentimes, if you don't treat quickly and get the bleed under control quickly, additional doses will be required that leads to higher costs. And so the cartoon is really just showing you what a joint bleed looks like. That happens to be in the knee. If we had other joints up there, it would look essentially the same. So again, we still have an unmet need with on-demand bleed treatment. So for example, patients with factor VIII and factor IX without inhibitors. So when I say that the health equity issue is that patients without inhibitors can use factor VIII or factor IX to treat their bleed, and that typically requires just one infusion. You can see that 80+% of the bleeds, regardless of which product you use across all the different trials that have been done, more than 80% of the bleeds, in fact, in many cases, it's even more than 90% of bleeds, will resolve with just one infusion. However, in patients with inhibitors, that is rarely the case, as I mentioned earlier. Typically, it's 2, 3, 4, 8, 10, 15 even infusions to get a bleed fully resolved. So we know for patients, regardless of what prophylactic medication you're on, and we know we now have prophylactic medications that can work in patients with and without inhibitors, but nevertheless, when a bleed occurs, life is very, very different for inhibitor patients because they are relying on bypassing agents, which often require these multiple IV infusions. And that's where we say that there's still this unmet need and this health inequity, if you will, when it comes to on-demand bleed treatment for patients with inhibitors. And again, that's for hemophilia A or hemophilia B. And so with that introduction, we'll get into 7-Fact. You can see the generic name is coagulation factor 7A recombinant, and then with a little hyphen, and then JNCW. Those 4 letters are essentially like a placeholder that's put by the FDA to make a distinction between other molecules that are coagulation factor 7A recombinant molecules. So that's kind of like a random 4 letters. So don't worry about that. In fact, we're just going to call this molecule 7-Fact for the rest of this discussion. So first, I have to talk about the indications, the usage, and some warnings about safety. So 7-Fact is indicated for the treatment and control of bleeding episodes occurring in adults and adolescents 12 years of age and older with hemophilia A or B with inhibitors. So just to unpack that a little bit, first you'll notice it is only for treating bleeding episodes. It is not for prophylaxis or prevention of bleeding episodes. Second, it's only approved for patients 12 years of age and older. There is a study that was done in pediatric patients, in case you're wondering, that wasn't ignored. However, it has not as of yet been approved for patients less than 12. If you're interested, you can search and find the pediatric 7-Fact study online. And the other thing is this is both for hemophilia A or B, so it doesn't matter which type of hemophilia you have, but only for patients with inhibitors and only to treat bleeding episodes. Also, 7-Fact is not indicated for the treatment of patients with congenital factor 7 deficiency. This is a statement to distinguish it from the other factor 7A that's on the market that I'm sure you've all heard of called Novo 7, which does have an indication for factor 7 deficiency, but 7-Fact does not. And then there's a boxed warning which says thrombosis. So the box warning is sort of an alert for a significant potential safety issue. And it says serious arterial and venous thrombotic events may occur following administration of 7-Fact, discuss the risks, and explain the signs and symptoms of thrombotic and thromboembolic events to patients who will receive 7-Fact, and monitor patients for signs or symptoms of activation of the coagulation system and for thrombosis. And then, just to be fair, is that the other bypassing agents, so the other drugs that we can use to treat bleeding in inhibitor patients, and I already mentioned one is called Novo 7, the other one you probably heard of is called FIBA, they have a similar boxed warning. So this is not like a unique boxed warning for 7-Fact. So the other two have the language may be slightly different, but they have also this box warning about thrombosis. So how does 7-Fact work? So it works at the site of bleeding. And so here we're looking at this 3-part cartoon. So on the left side, we show a bleed. And the first thing that happens is activated platelets, which are the cells that help clot the blood, go to the site of bleeding. And then 7-Fact essentially can generate thrombin, the thrombin burst. So it will work with factor 5A and 10, as you see on the left side, and then going to the middle, converting prothrombin to thrombin. Thrombin is really the key enzyme of the coagulation system. And this burst or sudden surge of thrombin, if you will, converts fibrinogen to fibrin. And fibrin is the protein that works with the platelets to make the clot. It's called fibrin because if you look under a special microscope, you can see this molecule as fibers. They are literally fibers that solidify the clot in between the platelets. The other piece here that is a bit unique to 7-Fact is that it binds to another protein called EPCR, which stands for endothelial protein C receptor. And by binding to that, it can further enhance the thrombin burst because that pathway, the EPCR pathway, is there to slow down thrombin generation. And so, or slow down the thrombin burst. So by 7-Fact binding to EPCR, it essentially is blocking that pathway so you can get a further surge of thrombin. And that's something that is unique to 7-FACT among the different bypassing agents, is its unique ability to bind strongly to EPCR. So, how was 7-FACT studied? So, we're going to get into now the study that was done. It was evaluated to see whether it was safe and effective in the treatment of patients with mild or moderate bleeding episodes. And so, the primary endpoint, you can see in the figure on the bottom left, was measured at 12 hours. And we'll discuss shortly what exactly was measured to determine if the bleed stopped. And then also, it was made sure to be effective through 24 hours. So we have essentially a 12-hour time point and a 24-hour time point that were critical to the evaluation of 7-FACT to see how effective it was. The patients in the study, you can see there were 27, which is a relatively small number, but of course, inhibitor patients are not that many. You can see their age range is 12 to 54, but what's important is that these 27 patients treated 465 mild or moderate bleeding episodes. So that's a lot of bleeding episodes. If you do some math, if I remember, it's about 17 bleeding episodes on average per patient that were treated in this trial. So while the number of patients is relatively small, the number of bleeds is really quite large. So let's talk about some terms that we're going to review. So this was a home treatment study. So patients got the 7-FACT to treat bleeds at home. And in fact, nearly all the bleeds, I think it was 98%, were treated at home. Patients did not have to come to the emergency room or be hospitalized or anything like that. And so part of the evaluation of what we call the therapeutic response, whether this drug worked or not, was really decided by the patients. The patients made this evaluation at home. Now, they were given this sort of scorecard, if you will. Excellent, basically at the top, means full relief of pain and cessation of objective signs of the bleeding. So, in other words, basically the bleeding stopped and no additional infusion of 7-FACT was given once that rating was made. Good was that the symptoms of bleeding had largely been reduced by the treatment but didn't completely disappear. However, the symptoms improved enough that no additional doses of 7-FACT were given. If the patient rated the bleed as excellent or good, that was considered satisfactory. You can see the thumbs up there on the right. The other two possibilities are moderate, meaning there was some effect of the treatment on the bleeding, but the bleeding had continued and continued 7-FACT was given, or none, meaning there was no noticeable effect of the medication. So this was one of the key points that was required to determine that the medication worked as far as the response to 7-FACT. So another term is the IDR, which we're going to call, so I'm going to call it the IDR. It's the initial dose regimen. Basically, it refers to the fact that in this trial, there were two dosing schedules that patients could use. Now, patients were assigned randomly one dosing schedule, and then after 3 months, they flipped to the other dosing schedule, and then after 3 months, they flipped back, and they continued back and forth. So the point here is that every patient used both of these dosing schedules to treat bleeding episodes. Again, these were the bleeding episodes that were considered mild or moderate. Severe bleeds had a different schedule. And the unique dosing was that we call one the 75 IDR and the other the 225 IDR. And that has to do with the first dose. So the first dose, if the initial dose, in other words, the initial dose, you see IDR, initial dose regimen, was 75 micrograms per kilogram, that's the 75 IDR. If the initial dose was 3 times higher, 225 micrograms per kilogram, then we call that the 225 IDR. So we'll get into that a little bit more shortly. So who were the people who were in this trial? So you can see it was 27 subjects or participants. Most had hemophilia A. Well, because we already discussed that most inhibitors occur in hemophilia A patients. And we also noticed that most had severe hemophilia. So that's just a fact, a matter of a factual matter that in hemophilia patients with inhibitors, most have hemophilia A, most have severe hemophilia. You see their mean factor levels all less than 1%. And the bottom talks about the inhibitor status, and I don't really want to get too bogged down here. Suffice it to say that in those three categories, what that meant was that these patients could not use factor VIII or factor IX to treat their bleeding. It didn't work. Either they had this high titer inhibitor or they had a low titer temporarily, but it would boost up if they got factor, or some patients had a low titer, but factor didn't work. So all these patients relied on bypassing agents to treat their bleeding episodes. And so that's what that bottom section means. So let's take a look at these dosing regimens. So we mentioned the 75 microgram per kilogram IDR, so that's going to be in purple. And that purple color will be continued to be used, or maybe magenta, whatever, throughout the rest of this discussion. And for the higher IDR, 225 micrograms per kilogram, it'll be in orange. So if you were assigned to the 75 microgram per kilogram IDR, then you would give that dose at what we say hour zero. So that's the initial infusion when you have a bleed. Following that, you didn't have to, but you could give additional doses of 7-FAC. Also, 75 micrograms per kilogram every 3 hours. So you can see hour 3, 6, 9, 12, 15, and so on. You could stop at any time. Anytime you felt the bleed resolved, the patient at home would not give additional 7-FAC. That could happen after the first dose, the second dose, or the fifth or sixth dose. For the 225 microgram IDR, you see things are slightly different. First of all, the first dose, of course, as I mentioned, is 3 times higher, 225 micrograms per kilogram. But then, if you gave that dose, you could not give additional doses until hour 9. And the additional doses, notice, are 75 micrograms per kilogram. So you only give the 225 dose once. Then, if you needed to, you could give an additional dose at hour 9, 12, 15, so on, similar to the 75 IDR. And again, patients would decide at home when they would stop treatment. When they felt the bleed was controlled, they would stop the treatment. And that could happen anywhere along this timeline. One thing to notice is that with the math is that if you were on the 75 microgram IDR and you gave a dose at hour 0, you had to, and then hour 3 and 6, by hour 9, you will have given 225 micrograms per kilogram, which would be the same total that the patient in the 225 IDR has given. So that's kind of why the study was designed this way. And the math working out like that is not at all a coincidence. So here's sort of like the headlines of the results, and we'll get into more details of the results in a second. So first of all, lots of different bleeds were treated, mostly joint bleeds, and you can see knees, elbows, and ankles, the most common, but also shoulders, wrist, hand, and hip, and also soft tissue bleeding, nose, mouth, or muscle bleeds as well. So basically any type of bleeding that a hemophilia patient can get was essentially found in this trial. And a key point is that 84% of the bleeds, so that's in that orange box on the bottom left, 84% of the bleeds were controlled with just one of the higher 225 microgram per kilogram doses. So it offers sort of some simplicity, some predictability, and obviously the ease of only having to do one infusion. And let me just go back to this slide just for a moment. And I did mention this before, but I want to make this point clear, is that all of the patients in the trial used both dosing regimens. They were assigned one dosing regimen initially, so either the 75 or the 225. But then after 3 months, they would flip. So if you were assigned to 75, 3 months later, you'd flip to the 225, and that's what you'd use for the next 3 months. And then you'd flip back 3 months later, and so on. So the point really here is that all the patients used both dosing regimens. So let's dive a little bit more deeply into the results. So first, the 75 microgram per kilogram IDR. The single dose efficacy, in other words, the effectiveness of this drug with just the one dose of 75 micrograms per kilogram was 29%. So, not great, but, almost a third of the patients just needed one dose that resolved their bleed by 3 hours. By 12 hours, it was at 82%, much better. And by 24 hours, you can see virtually all the bleeds, almost 97%, had resolved by 24 hours. For the 225 IDR, things look a bit different. At 3 hours, we have 84% of the bleeds had resolved, as I sort of showed you in that headline before. That's compared to the 29% for the 75. At 9 hours, which is the single dose efficacy, it's also at 84%. So 84% of the patients resolved by 3 hours, but separately, 84% of the patients only needed one infusion. By 12 hours, it was up to 91%, and by 24 hours, it was virtually 100%, 99.5%. So you can see there are some differences between the two dosing regimens, which I'll summarize a bit later. So first of all, let's talk about the 24-hour time point. I think at this point they're the two dosing regimens are quite similar. There's certainly not a statistical difference. There's not really a major difference there between essentially 97 and let's say 99%. So by 24 hours, either dose regimen was quite effective. But the important part of this slide is about the rebleeding. Rebleeding in patients with inhibitors is quite common. There's plenty of publications out there that discuss how frequent rebleeding happens. And the definition, in case you're wondering, of rebleeding here was bleeding in the same joint or anatomical location that happened within 24 hours of initial treatment. So in other words, once you stopped, if the bleeding happened again in the same place within 24 hours, that would be considered a rebleed. And so what you can see here is that only one patient, or not one patient, only one patient, but only one patient had one rebleed. So out of the 465 bleeds, there was only one rebleed, or 0.2%, which is, I think, quite an excellent outcome. So how does that look like, graphically? This is kind of showing the same figure just graphically. So if you look on the left, you've got the mild and moderate bleeding episodes that did not recur 24 hours after the treatment was completed. And that's 447 little blood droplets there. And on the right side, there's just the one blood droplet of the one patient that had a rebleed. So just to kind of emphasize the importance and the results of the rebleeding. Let's briefly talk about severe bleeding episodes. So severe bleeding episodes, these are considered either potentially life or limb-threatening, or they produce severe blood loss or pain that could cause permanent nerve damage, which means bleeding can occur inside the brain. And there you see, so inside the skull, we've got lots of different compartments you can see defined there. I'm not going to get into all these different compartments, but suffice to say that in hemophilia, if you have bleeding in the brain, God forbid, it could bleed in any one of these compartments or spaces. And in addition, there could be bleeding in the spinal column. And I've actually had that happen to 3 patients, which is also really serious because it could cause permanent nerve damage. So that's one type of severe bleeding episode. If patients had what they considered at home, so they would make this decision sometimes with their doctors, but sometimes on their own, a severe bleeding episode, then the dosing regimen is different. First of all, no matter which arm you were assigned to at that moment in time, you would give 225 micrograms per kilogram as the first dose. So even if you were assigned to the 75 for that time, if you considered the bleed severe, you give 225 micrograms per kilogram. And then what you see in the timeline is the difference as well, where you can give another dose of 7-fact. You don't have to wait 9 hours. You can give it at hour 6. And again, the repeat doses are all 75 micrograms per kilogram. So you can give a second dose earlier. And remember that the repeat doses for the mild or moderate bleeds were every 3 hours. And you'll notice here, 6, 8, 10, 12, 14, so on, is every 2 hours. So that's the difference if a patient had a severe bleeding episode. And in the Percept 1 trial, again, that's the pivotal phase 3 trial, there were 3 severe bleeding episodes, again, as rated by the patients. One was a traumatic intramuscular bleeding episode. That patient treated with a single dose of 225 micrograms per kilogram, and that bleed resolved. Another one had a spontaneous renal hemorrhage. Renal means kidney. He had blood in his urine, and he got 5 doses of 7-fact, the first at hour 0, of course, the 225, and then 4 additional doses of 75 micrograms per kilogram. And if you look at the timeline, that would be at hour 6, 8, 10, and 12. And the third one got his 225 microgram per kilogram dose for a spontaneous hip bleeding event, and then gave an additional dose of 75 at hour 6 and 12. Now you see it says protocol deviation there. It's because this patient mistakenly didn't give the additional doses at hour 8 or 10. It's not a big deal, but just making that point. So I think what you'll notice is these 3 major bleeding episodes all were resolved within 12 hours. So that's also, I think, a positive outcome for these patients who were receiving 7-fact. Let's get into the safety information. So this I have to go through in quite a bit of detail, but I'll try to make it quick but also interesting. So what is the most important information that you, as a patient, should know about 7-Fact? First, that the most serious possible side effect of 7-Fact is abnormal clotting involving blockage of blood vessels, which could include a stroke, blockage of the main blood vessel to the lung, which we call pulmonary embolism, or deep vein blood clots. And we've already covered that in the box warning, and also mentioned that this is not unique to 7-Fact, but other bypassing agents will have the same safety concern. You should know the signs, excuse me, you should know the signs of abnormal clotting and seek medical help immediately if they occur. And what are those signs? These can include swelling and pain in your limbs, so one leg or the other, maybe less commonly in the arms, new onset of chest pain, shortness of breath, which could be the sign of a pulmonary embolism, or loss of sensation or motor power, or altered consciousness or speech, which could be the sign of a stroke. What is 7-Fact? 7-Fact is an injectable medicine used to treat and control bleeding episodes in patients with inhibitors. We already discussed that in the indications. This part just says injecting medicines requires special training. It's almost a little funny to say this to a group of patients and families who probably have already had this special training repeatedly, but it's important to just say that if you haven't had this training, that you shouldn't attempt to self-infuse until you've been taught how to do so by a healthcare provider. Who should not use 7-Fact? You should not use 7-Fact if you are allergic to rabbits. I will come back to that because that sounds kind of weird. Or if you have known allergies to 7-Fact or any of its components. And if you have an allergic reaction, you should seek medical help immediately. This would include symptoms like hives, itching, rash, difficulty breathing with cough or wheezing, swelling around the mouth and throat, tightness of the chest, dizziness or fainting, or low blood pressure. And of course, you'll tell your healthcare provider prior to using 7-Fact if you were treating a bleeding episode with another bypassing agent, because there is no data and we should not be combining bypassing agents. So what's the deal with the rabbits? Well, 7-Fact is made in a unique way. It's actually produced in living rabbits. So the gene for 7-Fact is put into these special rabbits that are kept in a very special sterile facility. I can say that because I've actually been there and I've seen the facility. The way that we see it is there's sort of an external, there's a door that leads to this hallway that is really still outside because everything is surrounded by glass. So you're sort of still outside the facility, but you can see through the glass and see the rabbits. And so that gene is put into the rabbits. The rabbits then express the 7-Fact in their milk. And yes, these rabbits get milked repeatedly. And from the milk, then the 7-Fact is purified. And so that's where it comes from. So that's why we say that if you are allergic to rabbits, and there are some people out there that are, that you should not receive 7-Fact. Other important safety information, what should you tell your healthcare provider before you use 7-Fact, is you should tell them if you're pregnant or nursing or plan to become pregnant. Now, we know that hemophilia, especially patients with inhibitors, is not common to have in women, but just in case, it's important to say that because it has not been studied in women and certainly not in pregnant or nursing women. If you have had prior blood clots, heart disease or heart failure, abnormal heart rhythms, prior pulmonary clots or pulmonary embolism or heart surgery, or if you've had any other medical conditions, obviously these are things you should discuss with your healthcare provider in general, but certainly if the discussion of 7-Fact comes up, you should mention any of those things to your healthcare provider. And what are the possible side effects? So the most common side effects of 7-Fact that were seen in the trial were headache, dizziness, and then things related to the infusion. Infusion site discomfort, infusion site hematoma or bruise, and infusion-related reaction and fever. So if you have, again, seek immediate medical help if you have signs of blood clot or an allergic reaction. And then finally, if you or if a physician has seen an allergic reaction or, adverse reaction, so adverse side effect, those can be reported either to HEMA Biologics, and there's also a way to report them directly to the Food and Drug Administration. So we do have to always show you that. So I mentioned that this is made in rabbits, but don't worry, we're not injecting rabbit milk into you because 7-Fact goes through an extensive purification process, including viral inactivation, and then these other steps that I'm not going to get into the details of it. Suffice to say that at the end of the day, when you look at a vial of 7-Fact, you essentially have the pure 7-Fact protein in there, along with things we call excipients, which is substances that help to keep the 7-Fact in this powder form, as well as buffers and stabilizers and things like that. But it is, it is pure. It is essentially purified in this manner. So the safety profile. So what actually happened in the trial? So we already went through the potential or possible side effects, but what actually transpired in the trial? I already read through these, but you can see the numbers here, which is mostly things related to the infusion site discomfort, bruising, or infusion-related reaction, which can be like sort of fever or feeling funny after the infusion, and then dizziness, headache, and increased body temperature. Those are the numbers of adverse events in total. And that's in all the clinical trials. So remember, I said there were 27 patients in the Percept 3 trial, where there was another trial before that I didn't discuss. It was just an earlier phase trial that had 15 patients. So you see N equals 42 means this is from the 42 patients who had received 7-FAC through any of the clinical trials. And that's the total number of adverse events there, which adds up to 11. Importantly, in the 7-FAC clinical trials, there were no antibodies or inhibitors to 7-FAC, and there were no allergic reactions. Again, I discussed allergic reactions, and it does not mean nobody will ever have an allergic reaction to 7-FAC, so you should be aware of that. But in the trial, anyway, there were no allergic reactions in the patients who had that. And also, there were no thrombotic events in the trial either. And again, I mentioned that although there were no thrombotic events in the trial, that blood clots have been reported with similar products. So with NO07 and with 5 of the other bypassing agents, there are reports of blood clots. So it doesn't mean it cannot happen, but at least for what it's worth in the trial, it didn't happen. Let's talk about storage. So it's 7-FAC is convenient to infuse. You can infuse 7-FAC in 2 minutes. Once it's reconstituted, you have up to 4 hours to complete the infusion. So that's really for a situation where, if you have a hard time finding the vein and maybe you have to call a nurse or call a friend or come to the emergency room or something like that, that vial of 7-FAC that you had mixed already can be used up to 4 hours. Otherwise, it's easy to store. It is not, refrigeration is not required. You have to keep it between 36 and 86 degrees in your home. Obviously, everybody keeps their home somewhere between those temperatures. It should be protected from light, so keep it in the product package, preferably in some sort of closet or pantry or something like that, and do not freeze it because that's going to break down the protein and that won't work. And again, once reconstituted, you keep it at room temperature. So once you reconstitute it, don't put it in the refrigerator because it doesn't really help, and you can infuse it up to 4 hours if you're having trouble making the infusion. So if we compare based on the prescribing information, so this is taken directly from what we call the package insert or the prescribing information, we have NovoSeven in blue on the top of that timeline and 7-FAC using the 225 IDR in the bottom timeline. And with NovoSeven, the prescribing information states that you would give 90 micrograms per kilogram every 2 hours to treat a bleed. So if it took a full day to treat a bleed, the full 24 hours, you do 12 infusions. Whereas with the 225 IDR with 7-FAC, that would add up to 6 infusions if you had to use all the infusions. If we look at the 12-hour time point, it would be 6 infusions of NovoSeven versus 2 infusions of 7-FAC. So just a little bit of a comparison there. Okay, I don't know why that skipped a slide. I don't think I touched anything, but let's see. Okay. Yeah, I think that's pretty well the end of that slide. So just a bit of a comparison between the two Factor 7As on the market. So here's how 7-FAC is packaged. You're all familiar with how Factor comes. So it comes in a box, just like the other ones. And you can see there's the vial of 7-FAC, and then there's a pre-filled reconstitution syringe. So the liquid already comes in a syringe. And then there's the vial adapter, which has a little filter on it. And the pharmacy will provide an infusion syringe and other infusion supplies, as you're all familiar with that. And 7-FAC comes in 3 different sizes: yellow for 1 milligram, green for 2 milligrams, and purple for 5 milligrams. And depending on which IDR you use, and remember, it's weight-based, right? 75 micrograms per kilogram or 225 micrograms per kilogram. So depending on your weight and the prescription or the dose regimen that your healthcare team decides that you should have, then the pharmacy will send you the appropriate size vials. You may need to mix, 2 different vials, which you can do. So just to sort of summarize here before we get to just a few final points, With 7-FAC, we have rapid action. So 84% of the mild and moderate bleeding episodes were controlled with a single 225 microgram per kilogram dose at 3 hours. So rapid action. Remember earlier we were talking about some of the unmet needs and how often bleeds take a long time to resolve. The other unmet need was multiple infusions. So you can see then to the right at the top, 84% of the mild or moderate bleeding episodes were controlled with just one infusion of the higher IDR dose, the 225 microgram per kilogram dose, by 9 hours. So basically, a single dose, only one infusion, and that infusion in 84% of the patients works rapidly to control the bleed by 3 hours. The bottom is the efficacy at 12 and 24 hours, comparing the two different dosing regimens. There's definitely a bit of a difference at 12 hours, less so at 24 hours. As far as safety, again, in the trials, we had no thrombotic events, we had no allergic reactions, we had no antibodies, and no treatment-related severe adverse events. So that is adverse events that require things like hospitalization or more serious things. None of those occurred in the trial that were considered related to 7-FAC. And then other desirable effects include low rebleed rate of 0.2% that we covered, and that it may offer fewer infusions to treat a bleed. So what about Hemlibra? So this trial was done, because of course I haven't said anything about Hemlibra, and Hemlibra, as you are familiar with, is a medication that can be used in patients with hemophilia A only, hemophilia A with inhibitors, hemophilia A with and without inhibitors, but today's discussion is only about inhibitors. So it can be used in patients with hemophilia A with inhibitors to prevent bleeding. Remember, Hemlibra is only to prevent bleeding. So what about Hemlibra and 7-FAC? Well, the trial that I showed you was done before Hemlibra was widely available. So none of those patients were on Hemlibra because, again, this trial was done years ago before Hemlibra was commercialized. And so, what can we say about the two? So MASAC, which is the Medical and Scientific Advisory Council, it's a group of expert physicians, nurses, pharmacists who provide guidance to the National Bleeding Disorder Foundation, or NBDF. They support the use of 7-FAC for breakthrough bleeding events in hemophilia A patients with inhibitors who are using Hemlibra. They do recommend in this guideline, which is number 290, and you can find these on the NBDF website. They do recommend that if you're on Hemlibra, that you should use the lower IDR of 75 micrograms per kilogram, since you're already receiving a medication that increases thrombin generation. So, could 7-FAC be an option for you? Well, of course, only you and your healthcare provider can make that kind of treatment decision for you or for your loved one. And so if you have any interest in using 7-FAC, you should talk to your healthcare provider about whether it's a treatment option for you. And think about the questions below. So some of the questions to think about are, how long currently does it take for you to get a bleed under control? How many doses does it typically take to stop a bleed with your current therapy? And how often, for example, do you have to get up in the middle of the night to do an infusion for a bleed? So those are things for you to think about. And what you might ask your healthcare provider is, would 7-FAC be an option for me? If it is an option, which IDR is appropriate for me? And how could 7-FAC fit into my overall current treatment regimen? And then as we come to the end here, HEMA Biologics, which is the company that markets 7-FAC in the United States, has a support program called HEMA Biologics Cares. It's similar to some of the support programs you may be familiar with, and it offers a variety of things such as copay savings programs. So for patients that have copays, they can help cover up to $12,000 in your copays per calendar year. There's a patient assistance program. This is for patients who don't have health insurance or and don't meet certain income requirements. There can be some free drug that is given. There's a quick start program. So if you and your healthcare provider decide that, hey, 7-FAC might be a good idea for me, but now it's taken time to get the insurance coverage, you can get some free doses to start with until your insurance gets sorted out for receiving 7-FAC through your payer. There's a bridge program, so if people who are already on 7-FAC and then they change insurance and the new insurance is not covering it right away or there's a delay, you can get some doses to bridge you from one insurance to the other. And then there's a benefit investigation coverage determination that's really for helping the healthcare providers, so like people like me, my nurse coordinators, to work through your insurance to ensure that 7-Fact can be or is part of your program. And finally, prior authorization support, which is really similar to that as well. So if you have questions about that, you can talk to your HEMA Biologics representative or go to 7fact.com and then you can get some more information about that. And then there are patient advocates. So these are patients who are, well, two patients and one caregiver who have agreed to be patient advocates, and you can reach out to them, and you can see the phone number below, and you can speak to either Benjamin, who's a hemophilia A patient in his early 40s, who uses 7-Fact. Matthew, he has hemophilia A also, and he's in his early 50s. And then also a caregiver, a mom who's Rachel Katzman, who's a caregiver for a son with hemophilia A. So, yeah, those are additional resources for you, and you can see how to connect with them via email. I'll leave the slide up for a second so you can scan the QR code if you're interested in that. In fact, what I'll do is go to the next slide and come back to the QR code. So finally, just other places where you can get information. The website, 7fact.com. There's a reconstitution video there that can teach you how to reconstitute 7-Fact. If you like to use the phone, there's a phone number for medical information and for the support program, HEMA Biologics Cares. As you can see, same number, just different options. You can also email as well, or the patient advocacy hotline as well. So with that, I'll take some questions if there are any, but what I'll do is I'll go back to the slide that has the QR code so that if you're interested, that's a good way for you to watch the real life stories of Benjamin, Matthew, and Rachel and her son. So I'll stop there and see if we can take questions if there are any.
Super. Thank you very much, Dr. Young. Really appreciate this. Just before we go to the live Q&A, I just want to draw our audience's attention to the chat. There, you should find a chat icon at the bottom of your screen, and in there you'll see I've dropped a link to the 7-Fact prescribing information. So you can take a look at that. You might want to save that link so you can go back to it later. And you'll see it also if you're with us on the Restream platforms. You'll see that we've dropped that link into the comments there as well. So take a look there. Unfortunately, at this point, for technical reasons, we do have to say goodbye to our LinkedIn, Facebook, and YouTube audiences. So if you are on one of these platforms and you'd like to join us for the Q&A, you should see also in the comments there a link that you can click on to come on over to the Zoom platform and join us here. Thank you for joining us on those restreaming platforms, and do come back in a couple of weeks, November 5th, for the 4th NBDF HTRS Research Journal Club. And we will be looking at who is left out of bleeding disorders care, addressing health equity, with Doctors Carrie Norris, Angela Way, and Alison Wheeler. So we do hope to see you again then.